Hello, everybody. Welcome back to MBME 26. I'm going to be explaining 21 to 30 of section 2 of this test. Just to preface, all of these questions are my own. Go take the MBME yourself, then come back here. Let's not waste any more time. Question 21. 21? Okay, I gotta lock in here. Whenever you see cystic fibrosis, on test day, you should think of fat, soluble vitamin loss, and that should make you think of ADEK. Cool. Why does that happen? Pancreatic insufficiency. So the fat, soluble vitamin loss, especially vitamin K, occurs because in cystic fibrosis, you get the thick mucus blocking your pancreatic enzymes. So all this mucus just blocks up these pancreatic enzymes, can't get out. And those enzymes are important for digesting and absorbing fats. So now we don't have A, D, E, and K. And K is super important for something that most of you guys know about, clotting factors. Which ones? 2, 7, 9, 10. Also factors C and S. And so without vitamin K, the liver can't properly carboxylate those factors. And so the result is what? We'll check this out. Prolonged bleeding time and also easy bruising. So your job is to connect the dots between CF, pancreatic problems, fat-soluble vitamins, which factors are impacted, what they do, coagulation factors, and how they prolong bleeding. Also, think of foul, smelling, bulky stools. That's steatorrhea from fat malabsorption, easy bruising, ecchymosis, without trauma. So ecchymosis is going to be the discoloration of the skin that results from the bleeding that happens underneath, and it's typically caused by bruising. But in this case, it's going to be without trauma, just bleeding. So it's a vitamin K deficiency in the context of malabsorption. So cystic fibrosis, here are the associations and the pathophys. The big things to know is thick secretions block those pancreatic ducts. You get pancreatic insufficiency, so that's poor absorption, and fat just is not going to be absorbed like it should. One of those is vitamin K. And so in the pancreas, it'll block it up. Fat's not digested. Deficiency of clotting factors. Okay, let's do this practice question. We got a 4-year-old boy with known cystic fibrosis is presenting with frequent nosebleeds and easy bruising. His stools have been bulky and greasy, and on exam, he has multiple bruises over his shins. Labs show prolonged PT and mild, prolonged APTT. Which of the following deficiencies most likely explains his symptoms? The answer is going to be vitamin K deficiency. And the reason why is because cystic fibrosis leads to a fat-soluble vitamin deficiency, and we've explained this several times. Now, what about these other answers though? Vitamin B12. So that's going to cause macrocytic anemia, not bleeding. How about platelets? Well, that would cause petechiae and mucosal bleeding, but you'd see a normal PT, APTT. And petechiae is the small red and purple spots that are caused by bleeding to the skin. However, deficient platelets, you'd see the normal kind of clotting factors there. So the clotting factors really cues you into that. How about antithrombin? That would lead to hypercoagulability. There's not going to be bruising or bleeding. Next question, 22. I don't know if you guys ever watch Phineas and Ferb, but there's a funny episode with Doofenshmirtz is at the bottom of the lake with the Loch Ness Monster, and he's all like, zinc. What's the importance of zinc? Well, we're going to talk about that today. Steroid hormones act on the intracellular receptors, and they have zinc fingers. So let's say we have like a steroid like cortisol, for instance. Cortisol enters the bloodstream and it doesn't need a membrane receptor. What happens? It just goes straight into the cell, straight through the front door. Hey, DNA. How's it going? And that's because steroid hormones, they're lipophilic, and that allows them to just diffuse straight through the plasma membrane and then bind to receptors inside of the cell. And these receptors have a unique tool. It's called zinc finger motifs. And that stuff, the finger motifs, allows them to clamp onto the DNA and change gene expression. So you don't need second messenger stuff. You don't even need any of that fancy GS stuff that we were talking about in the other video. It's just direct gene transcription control. And that's why the effects are slow, but they're super long lasting, because you're affecting like the DNA transcription. So what do all steroid hormone receptors have in common? Well, zinc finger DNA binding motifs. Okay, I just wanted to explain that before diving into this practice question. Which of the following structural feature is common to all receptors of cortisol, aldosterone, and estradiol? So we know by now it's the zinc finger binding motif, but why are the other answers incorrect? So GTP neutralizing domain is found in G protein coupled receptors, so peptides. Transmembrane alpha helical, no, because they're not membrane bound. Tyrosine kinase, seen in insulin growth factors. Second messenger binding site? Nope, straight to the DNA. So just remember those zinc binding motifs straight to the DNA. It just walks right in, diffuses through because it's lipophilic. Get those zinc finger motifs. That's the answer. All right, there's 22. Let's just start 23 right here. And for this one, we're going to have to be real familiar with TB. Let's start with our practice question. 40-year-old man, history of homelessness, worsening thoracic back pain. We have anterior vertebral body destruction at T9, T10, narrow disc space. What's the cause? Answer is tuberculosis. Pyogenic osteomyelitis. So that would be rapid onset with fever, not gradual. Multiple myeloma. That would cause lytic lesions, but it spares the disc. So you'd have anemia, renal failure, protein gap. Metastatic prostate cancer, that causes your sclerotic lesions. So often lumbar would not involve the disc space itself. And osteovertebral compression fracture. That's sudden onset, wedge-shaped, no disc space narrowing. So what we have here, this is tuberculosis, and it's going to be Pott's disease. All right, so Pott disease, Mycobacterium tuberculosis just silently infiltrates into the vertebrae and it destroys the bone and the disc space over the period of several months. And it's not just like usual back pain, it's often localized and it's also insidious. So it's pretty gradual and it loves high-risk patients. So homeless, you'll see history like that, incarcerated, immunosuppressed. And on imaging, you're going to spot the disc space narrowing with vertebral destruction, especially in the thoracic spine. So there's no trauma, no fever, just a slow kind of grinding collapse. And that's going to be vertebral tuberculosis. You have your latent TB, and then the thoracic vertebrae are affected. You have the spinal TB and extrapulmonary TB, all these TBs, CNS, kidneys, adrenals, bones. Then you also have a risk of compression. So like kyphosis, cord impingement, neurological defects. So look out for gradual onset, localized back pain, vertebral body, homeless, immunocompromised patients. There you go. That's Pott's disease or Pott disease, tuberculosis spondylitis. Now, this is one of the most conveniently named nerves in the body, pudendal. I know these are sometimes long videos, but keep holding it together. Voluntary defecation control, the pudendal nerve. Origin, S2 to S4 for continence. Somatic nerve that lets your brain voluntarily control the external anal and urethral sphincters. And so if you get a patient who is experiencing pelvic trauma and surgery, the pudendal nerve can be damaged. And so they still sense the need to go, but they just can't. They lose the ability to hold it voluntarily. And so sensation and reflex tone can remain intact. Why? Because the pathways, like the pelvic, are still intact. So whenever you think of the pudendal, you're almost always going to also be confronted with the pelvic splenic. So the autonomic is the pelvic splenic, and that's still fine. And so in step 1, you'll see a patient who has the wink reflex and he has basic tone, but he loses voluntary control. So it's going to be pudendal from S2 to S4. And so the wink reflex, there's the anal wink and the jaw wink, the Marcus Gunn phenomena. So the anal wink is the superficial reflex that involves the contraction of the external anal sphincter whenever you're stimulating the perianal skin. The jaw winking reflex is a congenital condition. The blinking occurs and the jaw is like moved. So it's aberrant connection between the trigeminal and the ocular motor. Those are the two wink reflexes that you know in the human body. So practice question, we have a 52-year-old woman undergoes pelvic surgery and postoperatively is unable to voluntarily contract her external anal sphincter, but rectal tone is present and defecation occurs reflexively. So we know pelvic splenic is intact. Which nerve is injured? Answer, pudendal. Hypogastric, that controls your sympathetic function. Point and shoot, hypogastric. Ejaculation, not somatic anal control, so it's not hypogastric. Ilioinguinal, that provides sensory innervation to the groin and the scrotum, but not pelvic control here. So yeah, you still have some groin scrotum area, but not. Pelvic splenic, that's parasympathetic. Genitofemoral, that innervates your cremaster and your skin over the femoral triangle, and then it does not have a role in continence. Cremasteric reflex and skin over the femoral triangle, genitofemoral. Okay, there's some more information about it. All right, we just finished 24. Now let's do 25 right here. In a healthy, hydrated adult on a normal diet, which of the following filter substance is most likely to appear in highest fractional concentration in the final urine? So I know you guys have all kind of seen this graph where you have like your PAH, creatine, creatinine. It was Prime Day recently, so I've been on that creatine grind. And we have potassium and bicarb, amino acids, glucose. So over here, if it's less than 1, because this is going to be compared to water. And so when the solute is reabsorbed more quickly than water, then it's down here, like bicarb, amino acids. And so what's interesting here is we don't actually reabsorb a lot of that urea, but half of it ends up in the toilet. So urea is the byproduct of nitrogen metabolism, right? It's the highest fractional excretion among any filtered solutes in healthy individuals. So glucose is super reabsorbed. It's almost 0% in the urine. It's going to be just dumped. And so urea actually helps you build the medullary concentration gradient in the nephron. It enhances water absorption downstream. So if you're asked which solute has the greatest fractional excretion, the answer is going to be urea. It's filtered and only partially reabsorbed. Let's talk about what the other answers are wrong. Bicarb, super reabsorbed. You kidding me? Very low excretion. Sodium, tightly controlled, usually less than 1% in euvolemic patients. Glucose, that's fully reabsorbed, unless glucose is greater than 180, in which case it just exceeds the threshold, and then you'll start to finally not absorb it. Phosphate, partial, but its excretion actually varies with parathyroid hormone and dietary intake. And so it's still going to be less than urea, though. Are you kidding me? All right, that was question 25. Now question 26. So this is going to be an ethics question. And what I want you to know about the ethics is answers like this. Can you tell me how that occurred? Just open-ended questions are always going to be right. And you just want to make sure that you're avoiding leading questions. You just want to just say, hey, open-ended, what do you got? And this is actually going to be very important because every minute, 20 people in the US are physically abused by an intimate partner, and they won't say a word unless asked about it. So it's truly a horrific thing. So if you can spot multiple bruises, especially in high-risk areas like the neck or the face, then don't be accusatory necessarily. It's just observation and invitation. For instance, can you tell me how they occurred? Neutral, professional, And you definitely don't just want to avoid it. All right, 27. So be sure to comment if you prefer me to explain first and then question later, or question first, explain later. Probably the latter. We'll try it for this question. We have a 60-year-old man. He's got a history of chronic kidney disease, and he's admitted with hypertensive urgency, and he started on IV nitroprusside. And then after 2 days, he develops confusion, metabolic acidosis, dyspnea. Which of the following best explains the mechanism behind his symptoms? So you can kind of see at the top of the screen there. But essentially what happens is we get electron transport chain inhibition, so there's no ATP, and so you have a cellular energy crisis. And the pathophys for this condition is nitroprusside enters the bloodstream and it releases nitric oxide. And that causes what? Vasodilation and also cyanide. Okay, then cyanide binds to cytochrome C oxidase. You may remember that from MCAT. All right, so that binds there. That's going to be also known as complex 4. And what does that do? That halts the electron transport chain. So that's not working. What are you going to do? Lactic acid is going to accumulate because you're going to switch to anaerobic glycolysis. And so unless you detox them through like liver enzymes, then they're going to have hypoxia and organ failure. So if you know that nitroprusside metabolism produces cyanide as a byproduct, and that inhibits cytochrome C, then you'll know that you have lactic acidosis because of that shunting, or because toward the glycolysis pathway, anaerobic metabolism, and metabolic acidosis. Okay, increased hepatic gluconeogenesis. So that would actually not lead to acidosis or respiratory symptoms. It's just irrelevant. Increased prostaglandin synthesis, NSAID related. It's not going to be linked at all. So no. Inhibition of the carbonic anhydrase. That's going to be seen with acetosolamide. That causes a non-ion gap metabolic acidosis. So totally different. And direct adrenergic stimulation. That causes hypertension, tachycardia, not bradycardia, and metabolic acidosis. Because it knows your adrenals, right? So those are the nerve cells that epinephrine, adrenaline, noradrenaline, or other substance act as a neurotransmitter. So really, you just need enough of this nitroprusside that's released by the cyanide metabolism to then inhibit your cytochrome C, causing these symptoms to occur. Another ethics note that I want to give you, anytime they have you translating because you know stuff, don't do it. You have to have a medical translator. So let's just call that ethics for 28. 29. Before I do 29, I want to teach you the concept of Meckel's diverticulum. So basically, I'm going to teach you everything you need to know about it. Literally, if you look at first aid, there are 16 instances that you need to know. Here are all of them. An example of choristoma is where you have normal tissue in a foreign location. So like gastric tissue that's located in the distal ileum. Remember DJ ileum, duodenum, jejunum, ileum. So the gastric tissue is located there because of Meckel's diverticulum. That's one. And so what is this diverticulum thing we're talking about? Well, in diverticulum, you have a blind pouch that protrudes from the alimentary tract, and it communicates with the lumen of the gut. So most diverticula, so like esophagus, the stomach, duodenum, the colon, you just kind of acquire, and they're called false. But there's a true diverticulum that's all the gut layers, and that's Meckel's diverticulum. You know, it's true, all the layers. There's also diverticulosis. So many false diverticulum in the colon. And diverticulosis is often asymptomatic, but you could have some diverticular bleeding, painless metachesia, diverticulitis. And diverticulitis, that's inflammation of the diverticula with wall thickening, and diverticulitis can cause some left lower quadrant pain, fever, leukocytosis. You actually have to treat that with some supportive care with antibiotics. So Meckel's diverticulum is a true diverticulum, and it's caused by persistence of the vitelline duct, the ophthalmomesenteric duct. So this can contain ectopic acid-secreting gastric mucosa or pancreatic tissue. It's the most common congenital abnormality of the GI tract. And you can also see, the fresh, bright red blood in the rectum or the stool. That's usually what kind of alarms people. And you can see right lower quadrant, pain, intussusception, and obstruction. One thing you need to know about Meckel's diverticulum is the TC protectinate scan. It's called the Meckel scan for uptake. And you have to know the rule of 2s. 2 times as likely in males, 2 inches long, 2 feet from the ileocecal valve, 2% of the population, and 2 types of epithelia. It could be gastric or pancreatic. So gastric, pancreatic, 2 feet from ileocecal, 2 inches long, 2 times likely in males, 2% of the population, which is kind of a lot if you ask me. Okay. The other thing we need to know is intussusception. So that's the telescoping of the proximal bowel into the distal. This often happens at the ileocecal junction, oftentimes in infants. And so children will get Meckel's diverticulum, small bowel hematomas. So it's that failure of the vitelline duct to obliterate. And so you get an outpouching of the ileum, be a true diverticulum, and it can be asymptomatic. So maybe like to illustrate this, kind of outpouches there. There's your kind of colon, kind of goes through there. So it's a true diverticulum. Because your vitelline duct cyst kind of also goes in that same area there. And normally these things are just completely separate. This is also associated with your first pharyngeal arch. But yep, that ophthalmomesenteric duct, and that is everything you need to know about Meckel's diverticulum. And so in our practice question, we have a 7-year-old boy, painless rectal bleeding, metachesia, no recent infections, Physical exam is unremarkable. Got that technetium scan, 99 per technate. And it shows focal uptake in the right lower quadrant. All the stuff really pathognomonic. And then the question is, which histological finding will you see? Where you could see the pancreatic. And indeed, it's going to be ectopic gastric mucosa, because mucosa diverticulum can have that, and it'll secrete your acid, causing irritation and also the painless bleeding. Goblet cell hyperplasia. So that would be, goblet cells would be like undergoing hyperplasia and chronic inflammatory bowel disease like ulcerative colitis. Endometrial glands and stroma, that'd be rare there. It's more common with endometriosis. Lymphoid follicle expansion is seen in Peyer's patches. Smooth muscle hypertrophy seen in chronic obstruction or achalasia. So yeah, just know that 2% of the population has that embryotic plumbing that just never kind of obliterated. Persistence of the vitelline duct, left over from when you're just a few weeks old in the womb. And so then you get the ectopic mucosa secreting gastric acid. That causes pain, ulcers. And what do you do? Surgery. All right, next question. Last question. 16-year-old boy, worsening facial acne, time of puberty. He has closed comedones and pustules over his forehead and cheeks. He avoids greasy foods and has been using over-the-counter cleansers. Physical exam shows several inflamed papules. The following is the initial pathogenic mechanism. Well, this guy is one of the 85% of teenagers who experience acne, and it starts like deep in the hair follicle. In acne vulgaris, you have a microscopic little traffic jam. The keratinocytes start piling up inside of the follicle. They just like start clogging in the pore before any bacteria arrive. And then you get the formation of a comedone. That's the hallmark of acne. And then in some androgens during puberty, there's a sebaceous gland that gets ramped up through oil, and its oil production goes haywire. And so the sebum then becomes all that oil there, just like a feast. The Acetobacterium acnes. So it's literally the acnes is the microbial, which eats up that sebum, and it's thriving in low oxygen, oily environments. And so it proliferates, and then boom, you got a pimple. So accumulation of neutrophils, that's, have you seen like the inflammation that's secondary after the follicular plugging? It's not the initial cause of it. Collagen deposition, that's scarring, happens in cystic acne, but it's not like the actual cause. Melanocytis hyperpigmentation, so that's going to be associated with your post-acne marks. UV oxidation is going to be photoaging, so it can worsen with hyperpigmentation after inflammation. So indeed, it's hyperkeratinization of the follicular endophibulum leading to comedone formation. So it's that follicular plugging due to the hyperkeratinization. And so acne treatments, they either unclog the pores like retinoids, or they reduce the sebum like anti-androgens, or they just kill C. acnes like benzoyl peroxide. So the sebum is downstream from those androgens. It's caused by them. And C. acnes are killed by benzoyl peroxide. And you can shrink the pores. It's the retinoid. Shrink, androgen, benzoyl. Those are the mechanisms that you got to watch out for. So your retinoids are going to normalize your keratinization, which has gone haywire. Or you could give anti-androgens, kind of like your spironolactone is used for that, or benzoyl peroxide or antibiotics that just kill the C. acnes. So you'll see on the face, the chest, the back. It's that hyperandrogenism. Okay, this has been MBME 26, section 2, 21 to 30. Like and subscribe if you guys are interested in seeing more. We'll see you guys in the next video. Hi, med students. Welcome back. This is a review of MBME 26, questions 31 to 40. We are on section 2 if you want to follow along at home. These videos take a tremendous amount of time, so if you want to see more of them, like and subscribe. All right, let's get right into it. You have a 34-year-old woman undergoes emergency surgery for a perforated sigmoid diverticulum. 4 days later, she develops a fever and left lower quadrant tenderness. E shows 5 centimeter pericolic abscess containing air fluid levels. Aspiration shows thick, malodorous. Gram stain reveals many segmented neutrophils, a few gram-positive cocci, and numerous pleomorphic gram-negative rods. Aerobic culture and McConkey agar remains sterile, so it's anaerobic. Which organism is the most likely pathogen? So it is obliged to be an anaerobe. So this person had a gut perforation, and it's got some polymicrobial feels to it. The only microbe they're asking us to name is Bacteroides. So nothing grew on the McConkey plate, yet we still see gram-neg rods. That's how I know it's obligate. Also, anaerobes, they usually generate volatile fatty acids, and that's why it's foul smelling, because they undergo those fermentation pathways under low oxygen. Especially in like your colon, B. fragilis is going to be the king and the anaerobe king. And so there was perforation, so it got to escape. So obligate anaerobes are killed by oxygen because it lacks superoxide dismutase and catalase. So if you're confused on this question, the way to break it down is step 1, there's a breach. Got to give myself some room here. What usually happens with this is there's an appendix wall burst. Maybe there's a colon wall tear. And so your gut context mixed aerobes and anaerobes enter the peritoneum. So step 1 is a breach. Then the anchoring step, and this is where B. fragilis, it has a polysaccharide capsule that sticks to the mesothelium. And that triggers abscess formation by activating the complement. P. Then liquefaction. Liquefy. Sounds like a Harry Potter spell. And that's where the enzymes like collagenase, heparinase, they digest the tissue, leading to a necrotic cavity that then becomes hypoxic. Afterwards, we have the wall-off phase. So fibrin, PMNs, by the way, PMNs are morphonuclear leukocytes. It's a type of white blood cell. It's part of the innate immune system, first responders. So they seal that pocket, and these anaerobic conditions are super good for B. fragilis. So you have fever, leukocytosis, and risk of sepsis. So imaging, think gas bubbles. Therapy, give a metro and ceftriaxone that covers your aerobes, or piperacillin and tazobactam and carbapenem monotherapy. A complication could be portal vein thrombosis. Did you guys hear that? What happens when your phone goes off while you're studying? Chunk, throw it away. So why is not answer A? Well, E. coli is a lactose fermenter that grows just fine in the air. And this guy would show pink colonies. So it's not A. B. Pseudomonas aeruginosa. This is definitely aerobic. Also has a blue-green pigment. Oxidase positive. It's a hospital water bug, not anaerobic abscess. So definitely not B. C is our correct answer. D, Vibrio, is a marine seafood diarrhea. That's what we call halophilic. It's a halophile. It's an extremophile, basically. It thrives in high salt concentrations. So that's not it. And E, Proteus. That has swarming motility. It's a urease producer. It's also facultative. So this is going to be common in like UTIs, not a strict anaerobe. So many of you don't know this. I went to art school. I'm just kidding. I might think so, based on my drawings. And if you were to zoom in, right here, B. fragilis, normally it is just chilling in the colon. But then you get a perforation. It could be like a bullet wound, ruptured appendix, diverticular blowout. It will sneak into the peritoneum. The capsule helps it stick to the wall. Then the enzymes liquefy the tissue, and then you put the plate in room air and nothing grows. And that's the giveaway. That's how we know it's an obligate, obliged, be an anaerobe. So next time you see an abdominal abscess post colon surgery and the lab says that it's sterile aerobic cultures, then think of this guy. I call him the stinky superstar. The stinky superstar is B. fragilis, obligate anaerobe. Okay, there you go. That was question 31. So let's liquefy and wall this off so that our obligated anaerobe can start to grow and be the stinky superstar that it is. Okay, the next question is going to be 32. In this question, we have a 45-year-old woman undergoing orthotopic liver transplantation for primary sclerosing cholangitis. She's maintained on tacrolimus and low-dose prednisone. 2 months later, she develops progressive dyspnea, a non-productive cough, and a temperature of 38.3. That's 101 Fahrenheit. Arterial blood gas, 4 liters per minute, shows PaO2 of 48. Chest, E demonstrates diffuse bilateral ground opacities. Bronchial lavage yields large cells with basophilic intranuclear inclusions and surrounding clear halos. Which process best explains her gas exchange abnormality? Now, not many people know this, but 80% of adults carry CMV, and they do so silently. If you unleash your calcineurin inhibitors, then the virus can become super duper deadly. And so what we need to know about this female is she's post-transplant, and we have T-cell paralysis here. And so it lets the CMV erupt in the lungs, and it shreds the alveolar walls, and then you get these owl eye inclusions. So the CT shows the ground glass haze, and the PaO2 plummets even though you have oxygen. So it's a diffuse alveolar damage problem. So anytime on step 1, when an organ recipient between 1 and 6 months out shows interstitial infiltrates, plus you have cytopathic inclusions, then you should think of CMV. And then you have to remember that B, which is a correct answer to this question, diffuse alveolar damage from CMV is what occurs with these ally inclusions and your T-cell associations. Very important to know why the other ones are wrong. A, we'll zoom in here. So Klebsiella, you'd have current jelly sputum, lobar necrosis, and your inclusions would actually be silent. C, aspergillus. I made a video on this. It's called Everything You Need to Know About Aspergilloma. So that's going to be a 45-degree branching. It's going to be hyphae. And those cause nodular infarcts. You wouldn't see those diffuse GGOs. And GGOs means ground glass opacifications. That's like the diffuse stuff. It's usually, broadly, it's caused by a displacement of the air with fluid, inflammatory debris, or fibrosis. So edema or ARDS are the common causes of it. So yeah, it's not aspergillus. Pneumocystis for D. That's going to have your silver strain cysts, not nuclear occlusions. It's bat wing bilateral infiltrates. And E, crypto. That one we know has a thick polysaccharide capsule. And that forms meningitis or nodules, not interstitial pneumonitis, early post-transplant. So post-transplant, you really think of that CMV. 1 to 6 months after, interstitial T-cell paralysis by the tacrolimus, ally inclusions 45. That's what's going on in this patient. Next question. In this question, we have a 6-year-old girl is evaluated for easy fatigue during playground activities. Vital signs are normal. Cardiac exam reveals 3 out of 6. Mid-systolic murmur at the left upper sternal border and a fixed, widely split second heart sound. There is a palpable impulse along the left sternal border. Chest x-ray shows mild cardiomegaly with a prominence of the main pulmonary artery. Which congenital lesion best explains these findings? Well, I already wrote it down while I was taking notes for this question. It's an ASD. Anytime you see that fixed S2 splitting, you should really be on the lookout for your ASDs. And if these guys are untreated, it can actually pump basically double the normal pulmonary blood flow every single minute. So in the ostium secundum, ASD, you get high pressure left atrium blood that pours over here to the right atrium. And the right ventricle now ejects expanded stroke volume. And then so you get a signature fixed, widely split S2. That's what you hear on the stethoscope. So it's all that extra blood that's just whooshing around the pulmonic valve that generates the mid-systolic murmur, hence the 3 out of 6. The valve is fine though, just overworked. Then over years, your pulmonary arteries remodel and resistance will climb. And then the shunts can actually flick directions. And so you get a pink kid that's going to turn blue in what's called Eisenmenger syndrome. So basically non-varying split S2, a school-aged child, atrial level shunt. It's going to be ASD. PDA, patent ductus arteriosus, has a machine-like murmur, not mid-systolic. Well, I guess it could be. It's a continuous murmur below the clavicle, but definitely S2 not fixed. B, coarctation. That's upper extremity hypertension. So you'd see rib notching. Not going to be a flow murmur at your left upper sternal border. So really need some more of those factors for coarction. Hypertension, rib notching. And I said that was B, but it's actually C there. Sorry about that. B is our correct answer, obviously. We'll go on to D, tetralogy of flow. So that's going to be cyanosis, and it's going to have a harsh VSD. It's going to be S2 single, not that wide split. And then E is just a VSD. So that's a hollow systolic murmur at the left lower sternal border. And the splitting pattern is, all right, moving on. 34. Here we have a 48-year-old man on chronic hemodialysis. He's had a left forearm AV fistula for 6 years. Over the past month, he notes exertional dyspnea and new ankle swelling. 128/48, heart rate 96, resting 22. His extremities are warm with bounding radial pulse and continuous thrill over the fistula. We got an S3, basilar crackles, right heart cath shows high right atrial pressure. Pulmonary wedge is 20, so also high. Cardiac output is high. Which hemodynamic change is most characteristic of the underlying pathophys? Now, the best way to answer this is kind of with an analogy. I'm not a big car guy, but bear with me here. Imagine you rev up your engine every single day at redline. Well, eventually the motor is going to fail. And that's what happens when you have an arteriovenous fistula. It dumps the arterial blood straight into the venous system. And so the mean arterial pressure is going to crash. So stroke volume is going to go way up. Heart rate is going to go up, and the cardiac output can double. And the patients are going to feel warm to touch because the blood is rushing through the dilated capillaries. And yet they're also going to be drowning in pulmonary edema from shear volume overload, hence the S3. And so we have a fixed machine like Brewy over the shunt, and also bounding pulses with a wide pulse pressure. So the hemodynamics confirm that. High output, elevated mixed O2, but then also you have profoundly low SVR. And so the question is asked, which parameter changes first in high output failure from an AV fistula? Then think of the decreased systemic vascular resistance. Here are the other answers and why they're wrong. But the big takeaway here is you need to know an AV fistula is basically a shortcut from an artery to a vein, and it skips the arterioles. And so the heart, how does it react? It just pumps faster and harder, like Boxer from Animal Farm. So it gives you a high output state, low SVR, fistula. Question 34, done. Now I'm going to tell you about a retirement home, but first, incidence. Incidence is equal to the new cases over the total people at a given time. So it always updates the denominator. So the incidence here in this practice question, 2025, in a retirement community housed 2,000 residents. Now we have 50 were diagnosed here, and so we change the denominator as well. If we keep that same rate, then we get 0.025, 1,950, 48.75 rounding to 49. C. And so the only hard part about this problem is just adjust the denominator, change the denominator, and then you apply the incidence rate. That's it. All right, question 36. We have a 70-year-old man undergoes open repair of AAA post-op intravenous anticoagulant to prevent graft thrombosis. On day 7, the platelet falls from 220,000 to 90. Doppler ultrasound reveals a new occlusive thrombus in the left popliteal vein. Which drug mechanism best matches the agent responsible? Now, this is kind of paradoxical. One of the paradoxical things in medicine. The drugs we give to stop clots can actually ignite clotting cascades and crazy, just clotting friggin' wildfires. So when unfractionated heparin latches onto platelet factor 4, then it can create this complex that is like alien to the body. So by day 5, the immune system floods the bloodstream to try to attack this new alien with its IgG missiles. And so it locks on to the PF4 heparin, that complex that was formed, and it flips the platelets into overdrive. Kind of ironic. So they're going to spew out the prothrombic granules, and they form clots in the limbs and the lungs. And they also get chewed up in the process. And so the count is going to crash even though the thrombosis is raging. And so how do we save these patients? Well, we have to yank every form of heparin and then shift it to a direct thrombin inhibitor like a gatraban. So a 50% platelet drop between days 5 to 10 plus new thrombosis is going to be hit until proven otherwise. And so the guilty mechanism is the potentiation of antithrombin 3. And that's why our answer is B. Direct inhibition, that treats HIT, it doesn't cause it. So A is wrong. C, factor 10A blockers like apixaban, those lack your PF4 binding. And so you don't get hit from those direct ones, at least like almost never. D, warfarin, that affects vitamin K factors. So the early drop is protein C mediated skin necrosis. You wouldn't see thrombocytopenia. Skin necrosis is what you see for warfarin. E, aspirin, lowers platelet function, not your count. So it's not E. Easy peasy lemon squeezy. All right, question 37. Here we have a 68-year-old woman comes to the physician because of a 1-year history of abdominal pain after meals. You also see some weight loss. And then if she stops eating so much, she starts to feel okay. She had heart surgery in the past and her pulses are pretty low. Pretty faint, which is to nose, and so you get ischemia of the gut. Just to really drive this home, we'll do another question. 72-year-old man. This guy's got hypertension. Also, he's got epigastric pain, postprandial as well. Over 8 months, he has lost a lot just by eating toast, he says. Just a big toast guy. And exam shows a systolic bruit, just midline above the umbilicus and diminished dorsalis pedis. CT shows atherosclerotic narrowing of the major vessels. Which artery is involved? Again, SMA. Celiac trunk affect the stomach, not the small bowel. Splenic supplies the spleen, the pancreas. So how you think about this question is after a meal, your intestinal oxygen demand goes way up. But if you have like a super tight SMA, then you just can't meet that demand. So the bowel is going to be starved for blood. And so it releases lactate and pain signals. It's called intestinal angina. And so the patients will actually start to fear food and will actually trim their portions and shed weight despite having a normal appetite. And so if you listen with your stethoscope, you can hear a whooshing bruit in the epigastrum. And that bruit is going to be like a traffic jam. Beep, beep, of the SMA. Can't get the oxygen. And I did work outside a friend who always used to say, oxygen, I need oxygen. So your risk factors are always going to be like coronary artery disease, postprandial pain, SMA stenosis. That's how I want you to think about this question. 37. Look, guys, step isn't that hard. It's a whole bunch of memorization. What are we on? 38. For this one, we need to know the steps of change. Pre-contemplation, contemplation, preparation, action, maintenance. Now, 60% of smokers who reach 6 months smoke-free are going to relapse within less than a year. And that's unless they master this maintenance phase. So this is like very active. It's strategic. By 6 months, you have different habits like jogging routines, nicotine gum, support groups. This is all about your reward circuitry. Here they've kind of rewired, but you still have some old cues, right? The first beer at a party, you have the cravings. And so the maintenance focus on the coping plans. Like if X happens, then I will do Y. So here we have a man, he is 45 years old. He quit smoking 8 months ago after 20 years. He now jogs, tracks his cravings, nicotine gum. He tells his physician, I'm proud, but I'm worried my old smoking buddies are going to tempt me. Which stage is he in? He's already done the action. He is in the maintenance phase. Easy peasy. Pre-contemplation, somebody's like, I don't need to quit. Contemplation, yeah, I know the pros and cons, but I haven't done anything about it. Preparation, okay, I'm setting a quit date. It's kind of like for step 1, here you're like, I don't need to study. Contemplation, yeah, I know I should study. Preparation, booking your exam, setting a date. Action, this is your behavioral change, 3 months out, like a month out, and then maintenance. I'm worried I'm going to relapse, but nope, you just got to keep hiding Netflix. All right, that's question 38. Let's do question 39. Here we have a 70-year-old man who is admitted with fever, dysuria, confusion. Blood shows E. coli, 104. Wow. This is his temperature. And then his blood pressure falls to 88/54. It's like, dude, neutrophil activation is traced to bacterial lipopolysaccharide binding that signals. Okay, so here we already know the answer is toll-like. LPS is signaled by TLR4 on innate immune cells, and that triggers D88. So it's the pro-inflammatory cytokines. That's the answer. Toll-like receptors. Done. So here's what's interesting is 1/1000th of a gram of endotoxin can cause a fever, which this person clearly has. And so E. coli spills lipopolysaccharides into the bloodstream. This toxin gets shuttled to your CD14s and it docks onto the TLR4s. And so that causes dimerization. Then MyD88 can rush in, and then IRAC, IKB, all that cascade effect happen. Your IL-6s, blood vessels just dilate, neutrophils swarm, fever spikes, sepsis. So whenever they mention 8 gram negative PMPs, FKB, then the answer is just toll-like receptors. So you block the TLR4, toll-like receptor 4. If you block that, then even just tons of lipopolysaccharides aren't going to do anything. And that's the power of the innate immune system. Okay, that's 39. Last question, guys and gals, 40. So for this question, we have a 32-year-old woman, no past medical history, seen for headaches and persistent blurred vision. Blood pressure, holy cow, 200 on 3 separate visits, despite maximal doses of amlodipine, metoprolol. Oh my goodness. Pulse 56, physical exam shows low-pitched continuous bruit, 2 centimeters left of the umbilicus. Fundoscopy shows bilateral cotton wool spots. Duplex demonstrates peak systolic velocity, 350 centimeters in the left renal artery, Which of the following is most likely the underlying cause of her refractory hypertension? So this is renovascular disease. And basically what you're doing here essentially is you're just cranking up a garden hose until it kinks. And the pressure just skyrockets after that. That's fibromuscular dysplasia. That's what happens. And this is not a hose, it's your renal artery. And so here you'll see the beaded stenotic vessel, and it tricks the kidney into sensing that there's really, really low flow. And so then your juxtacellular glomerular cells, they go berserk. They just start pumping out renin like crazy. And then angiotensin 2 will tighten every single arteriole it can find. And aldosterone is just going to hoard your sodium in your water. So blood pressure is just going to soar. And this is going to be in somebody who's on test day for step 1. They're not going to give you somebody who's like routine atherosclerosis. They're going to give you like a 32-year-old, like kind of pretty young, somebody who's not going to have like atherosclerotic damage necessarily. And it's just going to be fibromuscular dysplasia in one of the renal arteries. And so one of the key clues here is the whooshing abdominal bruit, but normal potassium, and then a string of beads signature. So you have balloon angioplasty is going to pop up the narrowed segments, and that will also cure your hypertension. So young woman, malignant hypertension, and renal fibromuscular dysplasia. Okay, why is it not atherosclerosis? So atherosclerosis, there are different kind of risk factors and profiles here that are important to talk about. So A is not correct because that's going to be men older than 55 with hyperlipidemia. Also plaques in your ostium, not beaded mid-segment stuff. B is the correct answer. C, con adenoma. That causes hypokalemia. So it's like alkalosis, and the labs showed normal. And so it can't be cons. FeO. A lot of people choose FeO for this stuff, but that's paroxysmal hypertension, episodic headaches, and palpitations, and catecholamine excess, not renin. So that would be catecholamine, not renin. Coarction. That's like an arm-leg by blood pressure gradient. So that gradient there, and a coarction. Also, you have diminished ephemeral pulses and rib notching as well. Rib notching. And so a lot of these themes are just going to come up. You just have to keep grinding them out and memorizing this. This test is not about how smart you are. It's about how much you grind and how you know all these buzzy words. Wow, look at that. We hardly took up any room at all. How does rheumatoid arthritis present, by the way? MCP, PIP swelling, spares the dip, stiffness, less than 30 minutes after awakening, related ESR. You give them methotrexate and NSAIDs, if Intercept. See, it's just a bunch of memorization. That's all it is, which is stupid because we can just use artificial intelligence. We don't need to become redundant data repositories. But that's neither here nor there. This has been NBME 26, Section 2, 31 to 40. As I said before, this kind of takes a tremendous amount of effort. So if you got anything out of this video, please raise awareness of this channel, like and subscribe. Let me know how I can improve these videos. Next, we'll do 41 to 50, and then we'll do 27. Would you guys like me to do 27 all in one go? Like all of it? And maybe go faster? Want me to go slower? Want me to go in more detail? Let me know what you want in the comments, and I will tailor the prep to you. And you know that's true because I've made 640 videos in the past month or two. So this is definitely going to happen. And if we zoom out, we see, oh, look at that. Be sure to do that if you haven't. And remember that when you zoom out, we are just a little dot floating in space, so make sure that you have fun. Live a good life. You don't know how long you have left. Peace out.